Now, normally in presentations, the next slide that people see is the conflict of interest slide. And here you're looking at a stem cell, a very colourful stem cell, of course. And I'd like to say that my conflict of interest isn't that I firmly believe in cell therapy and stem cells. I firmly believe in getting the right answers to questions that we as medics and scientists want to address. So that in part explains my approach to the presentation. I'm not a skeptic. I'm not necessarily pro, although of course when you're trying to set up research you have to emulate some degree of support for what you're trying to do. I really want to find the answers and importantly answer the questions that comes from our patients about cell therapy, because as you're aware, the media has been flooded with a lot of attention regarding stem cells and embryonic stem cells and how they're going to change the world. And I think that cell therapy, if we get it right, and it's a big if, will revolutionize our practice of medicine, and that we will have to rewrite the textbooks that we as medical students will learn from, and those in the future will learn too. Why stem cells? Well, I think there are two aspects. There's a scientific answer to stem cells, and then there's a public belief. For some reason, in our patients, their minds are very much captivated by what stem cells are. I think they appreciate at a very superficial level the fact that cells that have the potential to form something as complex as a little baby can clearly have the potential to make them better, whatever the illness that they're having. And obviously at a scientific level, I think one of the big questions about the meaning of life for science is how two cells can go on to become such a complex organ. And I think we also have to put into context the fact that embryologists have been trying to solve that question for many, many years. And although the focus on cell therapy, so stem cells as a therapeutic, I think has accelerated the field, it still hasn't answered the question and still doesn't get in the way of the very important experimental and developmental biology that needs to go on to understand this fundamental question about the meaning of life. And as I said to you, I think you're aware of the fact that certainly in the media there are all sorts of claims about where cell therapy might well have a role. And as you can see on this slide here, there are all sorts of organs and disease processes that are being targeted in research. And as far as I'm concerned, the more the merrier. We need to do a lot more research into this area. Of course, there are the issues of funding, but potentially there is so much to gain from this revolution in the way that we're going to treat patients. I firmly believe that we need to invest in getting the right answers. So going back to the heart and focusing on what we've learned, the field has been going for at least 10 years in its entity as a therapy rather than the developmental biology. And we know from the work that's gone out there that in preclinical experiments in the labs, that all these cell types that you see before you have been used experimentally to improve cardiac function. And that sort of goes back to the question about what's the optimal cell. And in a way, if all of these cells are as successful as each other in improving cardiac function, to translate that into human biology and human clinical practice, it's the pragmatic approach. So the question for a clinician is what's the easiest cell to use, and for a scientist perhaps is what's the mechanism and what cell has the greatest potential. For me, the answer to that question really comes down to two very simple defined areas. The adult stem cell is the pragmatic approach that clinicians can use to try and deliver cell therapy and start performing clinical trials which have already evolved. Again, about 5 or 6 years ago, work was published suggesting that the bone marrow was the source of cells that could potentially repair all sorts of organs in response to the daily homeostatic damage or processes that are needed for us to sort of get through each day and the organ damage that we succumb to, but clearly not in the magnitude that's needed to deal with pathology. So this homeostasis process that we think is identified with the human bone marrow as a source is clearly not of scale to deal with myocardial infarction, stroke, and large amounts of liver damage. And the other side of the coin is the true potential, the embryonic stem cell, simply because the potential of the embryonic stem cell, and these are what I define as true stem cells, so when I use the word stem cell, I'm talking about the embryonic stem cells, is that of course they can divide it infinitely and they can form any cell type in the body. So given the scale of the problem that we have to try and address with cell therapy, there is no doubt that the embryonic stem cell is the answer. but there is also no doubt that because of its flexibility and its potential, we have to handle with care and caution. Clearly, a cell like this, which has the potential to form you and me in our complexity, has also the potential to go catastrophically wrong. So we have to be very, very careful in our handling of the embryonic stem cell to ensure that we cover all the mechanisms that could be at play in developing the target, so for us cardiomyocytes, shall we say, and not developing something else, such as tumours through karyotype instability. And I think we have learnt lessons from the very beginning of what's happened with embryonic stem cell therapy, and that what you're seeing here in an organ that seldom undergoes mitogenic transformation. So the heart, as you know, seldom gets cancers. When you inject stem cells, embryonic stem cells, into heart muscle in animal models, you unfortunately get the development of teratomas, which you can see down there at the bottom, as defined by the multiple cell types that they expose. Now, this work is somewhat old, but still highly relevant, because the graph that you're looking at on the right really emphasizes the point that as we're trying to recreate the damaged heart, we need to inject more and more cells. And unfortunately, this potential to form teratomas seems to get worse the more cells that you inject. The preclinical experience really goes back to about 2005 when data was published that complemented the work that was done in 2001 by Ulrich and colleagues, that demonstrated that in the mouse model of myocardial infarction, injection of sibling-related bone marrow cells, these were actually selected cells into the border zone around the infarct, led to two important things. They demonstrated mechanism, and that's the top right panel you're looking at, where they co-labeled myosin stain with a tracker for the injected cells, and basically showed that the injected cells, so bone marrow-derived cells from sibling littermates, were able to transform into cells that expressed the red dye, which essentially is a myosin stain. So they claimed that this mechanism was in place to lead to the improvements in cardiac function that you see at the bottom, with what's down here is normal echocardiographic function in a mouse heart, to loss of anterior wall contraction in the model that they had, to some recovery of function. And the real news-grabbing point about this research was the 40% improvement in ejection fraction. So in a mouse model of myocardial infarction, they were seeing improvements in cardiac function that we had never seen in human medicine to date. And that's really why the stakes were so high. If we could affect 40% improvements in cardiac function, we would be in the position of transforming cardiovascular disease. The pragmatic approach in humans has been to use the bone marrow as the source of cells, and that has led to the questions about delivery. And what you can see here are the various different types of techniques that have been used in man to deliver bone marrow-derived cell therapy and some of the other cells, which we'll talk about later, into the heart. But to date, the technique that's been used the most is the intra-coronary approach, partly, again, because it's pragmatic, it's simple. And again, if you're thinking about distributing this technique and cell therapy throughout Europe, it's the technique that's going to be the easiest to deliver in an interventional cath lab setting. And this technique involves taking 50 to 100 mils of bone marrow aspirate in a procedure that involves local anesthetic and purifying or removing the red cells in the various techniques, and then re-injecting the concentrate down the coronary artery, which you can see on the right there, into the culprit vessel. And here we're talking about acute myocardial infarction. And the early work, which really has stood the test of time, has looked at ejection fraction, that you can see measured in this column over here, and basically demonstrated that the ejection fractions for cells injected into patients shortly after myocardial infarction seem to change by about 6% in a positive way. But importantly, you'll also notice that with the test of time, most of these studies looked at the improvements in cardiac function at about 6 months. Some did a little bit longer. But when they came back to look at these patients, you'll see that some of the significance was lost at about 18 months. And the skeptics of the field will draw your attention to 2 points. Firstly, that 6% at best is pretty meaningless in the world of cardiology as far as improvements in ejection fraction. And even when you get that, in that study, which was the BOOST study, you'll see that at 18 months it went to 2.8% and was not statistically significant. I think what's important to remember is that this is pioneering work. These are the first trials you're looking at in which we injected cells back into the heart, or colleagues injected cells back into the heart. And it's amazing that we got any improvements at all if you think about the overall scale of how we develop new things. And we also have to reflect on the fact about ejection fractions, and I'll come back to that later. It's all very well measuring cardiac function in an animal model because you can't measure the other things that we measure in human beings, namely well-being and the like, and return to work. But does a 40% ejection fraction in a mouse model of myocardial infarction, improvement, sorry, of 40%, translate to a 40% improvement in man? Maybe not. And this goes back to one of the big philosophical and scientific debates about our use of animal models in trying to develop new therapies for human beings and their exact relevance. The other point about how we affect change in cell therapy is the observation that there are two things that happen in the infarct zone. One is complete loss of function, which I guess is the global problem, but that's as a result of cell necrosis and damage, but also to do with the process of stunning. And the challenge that the field of cell therapy has is that we lose billions of cells during an acute myocardial infarction, even if it's optimally treated. So any technique that professes to try and do what the embryonic stem cell we hope one day will do will have to safely generate billions of cells to actually repair the scar that's being caused by the infarct. And not only is it an issue of scale, the number of cells that need to be produced, it's an issue of structure and function. So those cells have to integrate into their environment, and they actually have to be able to perform and electrically connect to the cells around them to work. So it is a very, very big problem. And as you know, our only therapy for myocardial infarction at the moment, or heart failure, that replaces billions of cells is cardiac transplantation. In the UK, even though we have close to 800,000 patients suffering with heart failure, there were 40 cardiac transplants performed in adults last year. So again, we're never really going to have human donors as a source of this problem and the billions of cells that we need. And the question that then arises is that, well, if you're using bone marrow cells, we get these small improvements in cardiac function. And if we want to aim to restore the heart by using embryonic stem cells and generate billions of cells, what exactly is going on? Why are we seeing any improvement at all? And several authors have come up with various suggestions as to how that might occur through cell fusion, and that's some sort of buddy effect of the injected cells getting perhaps cells in the hibernating part of the myocardium to start working, the growth of new vessels and vasculogenesis, paracrine factors through all sorts of mechanisms improving cardiac function, and the holy grail of the field, which is transdifferentiation, which is the growth of new cells. But it's really in our research that we focused on the paracrine factors, because I believe in the bone marrow cell, despite what people say about multipotent adult progenitor cells and their source in bone marrow cells, I think it's the paracrine effect that really accounts for these small changes that we will see and the potential benefits we will see in humans in the trials. And our way of thinking about this was really to, rather than reinvent or invent new pathways, it was to consider what's out there already. And we certainly know that in ischemia reperfusion injury, there's some very well-defined pathways involving different signaling mechanisms. And the question we wanted to address was whether perhaps the use of bone marrow cells, either directly or through a paracrine mechanism, could actually modulate some of these ischemia reperfusion pathways and, in fact, switch on some of the survival pathways to cause benefit. And what we saw in a rat model of acute myocardial infarction, where we tested this hypothesis, was that bone marrow cells certainly did decrease in the area at risk the number of necrosed cells as compared to a saline injection and the number of cells undergoing apoptosis. And we showed some of the mechanistic aspects of apoptosis to confirm that wasn't just a chance finding. And we got as far as demonstrating that, yes, indeed, the bone marrow cells did influence some of the survival pathways, and that potentially all that we're doing with bone marrow cell therapy is taking on ischemia reperfusion injury, and as you know, ischemic preconditioning and post-conditioning has got a similar mechanism, and maybe we're doing ischemic post-conditioning with cell therapy. Could it be that simple? And if it is, then why are we trying so hard to do it with cells when we can do it with a blood pressure cuff in the back of an ambulance? That said, we don't fully understand the mechanism, and of course the survival pathways might just be one part of a very important spectrum of mechanisms that are important and will come into play. And what you'll see is that when you look at the meta-analysis of all the clinical trials, and this is now talking about heart failure, so established myocardial damage, we get this answer of about 3.5%. That's a 3.5 to 4.5% in ejection fraction in all these trials in meta-analysis. Now bear in mind the tool or the trick of meta-analysis is to try and look for effect in any way, rather than to actually come up with a definitive answer. As you recall, however, our policy on use of aspirin is actually designed in and around meta-analysis. But that said, generally meta-analysis is to look for indicators of mechanism or indicators of effect that then lead on to do the large-scale trials. But our highly skeptical clinical colleagues in this field of interventional research will always draw our attention to the fact that 3.5%, we don't understand what on earth that means and how clinically relevant it could be. And of course, they're slightly missing the point. The point is that there is this statistically significant benefit of using cell therapy, and these are bone marrow cell therapy, in patients with established heart failure. The magnitude of effect is debatable, and we'll come to that in a little while. But the question is indeed valid. What does 3.5% mean in human beings? And I'd actually argue it probably means a heck of a lot. It might even mean as much as 40% in a mouse model, but nobody's ever looked at that. And I think that's a very important tool that we need to do when we use animal models to translate into human beings. We need to really understand what that model is saying about human biology, if anything at all. So our approach, which I've been hinting at for a while, was essentially based around the European Society of Cardiology's task force report that was written a few years ago, back in 2006, where we looked at the work that was out there and tried to look at a way of stratifying our approach across Europe. The danger at this stage, so 5 or 6 years ago, was that many centres were developing their own approach to cell therapy. Many clinicians had bought into it, despite the scepticism. And some indeed at the time were offering it as a recognised therapy in their centres. So some patients in certain parts of Europe were receiving cell therapy as part of routine practice as an adjunct to acute myocardial infarction. So of course, from our perspective, it was very important to make sure that we try to address the questions in the field in a uniform and pragmatic way. Clearly, funding these trials is always going to be a big issue, and the purpose of this publication was to try and make people think in the same way as the sort of trials that we wanted to do. The recommendation is that we designed large randomized controlled trials to look at the different patient groups, that we used autologous cells in small clinical mechanistic studies as we try to support what we would see in the clinical trials by understanding mechanism, and that we also considered the so-called paracrine approach, and that the approach looking at cytokines and other proteins was obviously very important because that would massively simplify the way of delivering this therapy. Our approach at my hospital in London, so we're a hospital that does about 3,000 angioplasties a year. Its heart attack centre sees about 1,000 patients coming each year. So we're one of the biggest centres in the UK as a cardiothoracic unit, was to take that patient base and look at the three main problems that we faced in that patient base. And that was patients with established ischemic heart failure, to address the question, what about those long-term heart sink patients that we have in our clinic that we've done everything for, they've had CRT, they're on optimal medical therapy, and yet they're still very symptomatic and they're just essentially hanging on there with very poor quality of life, not getting better, not getting worse. What about the acute myocardial infarction group? As opposed to the studies that had gone before, our argument was that the animal models actually suggested that the acute administration of cell therapy is likely to be the most beneficial. And to date, nobody has done a randomized controlled trial of administering cells as short as 8 hours after the primary angioplasty event. So our aim was to establish that as one of our trials for acute myocardial infarction, the REGENERATE-AMI trial. And finally, the group of patients with dilated cardiomyopathy. And here we're deviating perhaps the most from the mechanistic answer to these questions. Although interestingly, talking to Manolo, some of the mechanisms that he's exploring in his work here to do with mitochondrial function might well play a part in dilated cardiomyopathy, because, as you know, a lot of the dilated cardiomyopathies are to do with mitochondrial problems. And one of the very interesting things that might come about is that maybe cell therapy, actually bone marrow cell therapy, modulates mitochondrial function. So all sorts of mechanisms, a lot of which I haven't even listed, that could potentially explain what we wanted to do. What was the driving force here? The driving force was simply our patients. So we were being inundated at the time with patients asking us, what's going on with cell therapy? Why aren't you doing it here in the UK? Where can I go to get it? It seems to work. So what we wanted to do is to design randomized controlled trials to try and answer that question and actually give our patients the benefit of knowledge rather than speculation. So the first trial that we got going has been running for now 6 years and is just about coming to an end. The REGENERATE-IHD, so these are heart failure patients. They're at least 3 years from their last myocardial infarction, so they're that group of patients who have survived, but they are NYHA class 2 to 4. They've been turned down by heart transplant, they're on optimal medical therapy, and they will have had resync therapy if indicated. And what we wanted to do in this trial was to address head-to-head the question about how you administer cells. So as you're aware, the problem with ischemic heart disease patients is they've all had infarcts, and therefore the concept of injecting cells down a coronary artery that's secluded is somewhat alien to interventional cardiologists and most people. That said, of course, these people do form collateral circulations, and so injecting cells into their coronary circulation means that the cells potentially can get somewhere. But the thought at the time was that intramyocardial injection was obviously much more direct. The drawback about intramyocardial is that it takes very specialized equipment, which I'll show you in a minute, to do, and therefore is not as universally available. And ultimately, the pragmatic approach, something that is deliverable to everybody wherever they're at around the whole of the country in their homes, is answering the question whether simply cytokine mobilization of stem cells, or bone marrow cells, should I say, using GCSF will actually work. And that's the column you're looking at on your far right, the peripheral non-intervention group. So this is the first time there's been a head-to-head comparison in the randomized controlled trial of the different types of injection techniques and also the effects of cells versus serum on ejection fraction outcome in these patients. This is the animal data that is frequently used out there to convince us about the issues to do with intramyocardial versus intracoronary, and it uses a radio label of technetium to look at technetium-labeled bone marrow cells. And you can see that when you inject cells intramyocardially, there's considerably more retention of cells than there are if you inject them intracoronally. Interestingly, though, however, that signal does decline quite rapidly with time. So one of the other problems that we face in the field is how to get the cells, even if you can stick them in the right place, to actually stay around for long enough to have an effect. And it might be that's one of the therapeutic approaches that we need to consider if staying around in the myocardium for this short period of time actually leads to some improvement in cardiac function. So that's why we designed this head-to-head, is intracoronary, which most cardiac cath labs in all of the European states can perform as good as intramyocardial. Few cath labs can do that. The equipment's very expensive. And ultimately, could this therapy be administered by a district nurse, for instance, in the patient's own home? Could we give patients repeated injections of GCSF to mobilize their stem cells and get the same effect? You'll also see that all of the interventional patients are treated with GCSF. And it became clear over the last 5 years that GCSF does have many other important features to it. Not only is it able to mobilize cells, but it also primes them. And there's a concept now that bone marrow cells need priming before you start to use them therapeutically. I must say this has nothing to do with great expectation or thoughts. This is purely by chance that the subsequent data that's come out in the last 5 years has validated our approach of using GCSF. So all our patients get pre-treated with GCSF, and you can see there's one true control arm, and that's the placebo that's actually hanging around over here, that actually only gets cells. And it's interesting, the patient's expectation about cell therapy is such that they're very disappointed about going into a randomized controlled trial in which they might not get cells. So these studies are incredibly hard to recruit for because the perception is that cell therapy works, and patients don't want to be in a trial in which they might not get cells. Delivery method. So as you've seen in the preclinical work, and there's now some human work to suggest the same, the intramyocardial technique seems to work the best. This is the NOGA system. The kit itself is somewhat expensive, so it's a computer-based system that you can see here in our cath labs. Essentially, the actual piece of equipment that's of interest is sitting here. It's a screen. We're using fluoroscopy as well. But basically, the equipment is a contact mapping, a bit like the CARTO system in the EP world. The electronic software costs about £15,000 or 18,000 euros, and it costs us approximately 2,000 euros worth of equipment each time we map and inject a patient. So although intramyocardial sounds like a great way of administering cells, it is incredibly expensive, and it ought to have a massive effect if it's going to be out there in the future for the health economic side of things. At the moment it's research, and that's what we're doing, and let's see what comes of it. So where have we got to in that study? Well, through the natures of the ethics committees that we had to go through to do this, we were asked to actually unblind our study after the first 50 to 60 patients. The ethics committee were obviously very skeptical about what we were doing. There was very little data out there as to anyone else who'd done it before. And so rather than allow us to complete the whole study, they wanted data to be looked at really from a safety perspective at the first 60 patients. I'm not showing you safety data, I'm showing you some tantalizing data. This is obviously early unblinding. It's not powered to show any statistical significant difference. But you can see that generally the NYHA class in these patients, so do you feel better and can you measure it objectively using the NYHA score, does seem to improve simply from being in the trial. Everyone gets better being in the trial, and that makes the very important point about what you'll see in the literature. If you don't do a randomized controlled trial in this field, your patients will get better anyway, whatever you do to them. Patients get better from being involved in something they think is going to work, and that you actually police by getting them to come to your clinics and follow up. So you have to do randomized controlled trial studies in cardiology in general, and particularly in cell therapy when all the patients think it's going to work. It's absolutely crucial. What you can see is the change here between baseline and 6 months. So we haven't split the patients into whether they had cells or placebo. I'm still blinded to the study as the PI, so I'm not allowed to know that information in detail. But NYHA class seems to improve, and it seems to have reached statistical significance. Of course, I'm going to say it was never powered to do that in the intramyocardial arm, perhaps backing up the data I showed you before about intramyocardial injection. When you look at the actual intramyocardial arm, it appears that it's only the patients that got stem cell injection versus the placebo patients that got better. Again, it's very small numbers, 4 and 9 in the two groups, but again, tantalizing that something's going on. For me, the most dramatic part of the trial was actually talking to the patients, because it became very clear from an early stage that about half the patients got better. And remember, these are patients who've been in heart failure clinics for 3 years with nothing making them better. And it's also interestingly, from the placebo point of view, that half of the patients didn't actually feel better. So these patients came wanting something to be done. They came with a belief in cell therapy because, unfortunately, that's essentially how they heard about our trials. But half of them were brave enough to tell us that actually it made no difference to them, and here they are. And interestingly, you can see that the angina class also drops. And again, unless there's a process of angiogenesis going on that somehow restores blood flow to the heart, you might expect their angina class to get worse, because you're not revascularizing them. You're giving them the ability to exercise more potentially, and even if it's a placebo effect, if you haven't changed somebody's revasc status in their heart and they think they're going to go out there and start running around the block and riding their bicycle, they're going to get a lot more angina because they've got ungrafted or unseen vessels. But again, you can see here that, interestingly, their angina score gets better. So this convinced the ethics committee that we were able to complete the trial. I'm pleased to say that the update on the trial is that in the intramyocardial arm, we've actually completed it and unblinded it about a week ago. I have seen the preliminary data, which I don't believe because it's too good to be true, so I've sent it back to my team to analyze yet again, and we'll go through in great detail as to what's going on. So tremendous excitement because it looks as though something important's happened, but obviously we're not going to jump the gun until we're absolutely sure that that data is correct. The intra-coronary arm has just got one more patient to treat, and the peripheral group has got 4 more. Remember, the follow-up period is 1 year, so we won't have the full results of the study, the head-to-head comparison, for another year. But we'll probably publish the intra-myocardial arm if it is positive early on in the summer. The next trial I spoke to you about was tackling the issue of acute myocardial infarction. Can we reverse the clock? By giving cells at a very early stage after acute myocardial infarction, can we restore cardiac function to a state at which it was in before the infarct, and thereby potentially saving the patient the problem with the scar formation that might occur? It might well save the patient and the number of tablets they need to take, and it certainly should get them back to work into a normal quality of life. So this study was funded by the UK Stem Cell Foundation. Again, it's the first randomised controlled trial in which cells are given at such an acute stage, and at the moment we're averaging to give cells back 6 hours after the primary angioplasty event. The patients are randomised after they meet the inclusion criteria, which is LV dysfunction following an anterior infarct, into saline or a bone marrow aspirate. And as I said, the cells are reinfused at 6 to 8 hours. We put 4 hours there because that was our initial hope, but the truth is it's 6. They undergo standard care for 3 days, so we try and discharge them as early as possible unless they've had a big infarct. So again, health economics are very important. The aim of this study was not to prolong patient stay, and you need to know that a lot of the work that's out there that was done in Germany, the patients were being treated at day 5. Well, certainly in our hospital, and by the sounds of it, this hospital, we don't have infarct patients in our beds at day 5. So it's a very important issue about health economics. You don't want to invent a procedure that doubles the length of stay of a patient in your hospital when the beds cost so much. If you're going to double the length of stay for a patient, this had better work in a big way. And we know it's about 3 or 4% if we're looking at ejection fraction as a surrogate. So there's absolutely no point developing a very expensive technique that means that you block your beds for even longer. It's just not going to happen or take off. Again, we've had some tantalizing results. So again, we weren't allowed to complete the full study without the ethics committee seeing the first bit of data. And what you can see as far as ejection fraction at 3 months is that some patients seemingly get dramatically better and some patients get dramatically worse. This wasn't an ejection fraction-based inclusion criteria, which is why some of these patients seem to have quite amazing ejection fractions. And bear in mind, MRI ejection fractions tend to be higher than the ones that you see on echo anyway. But again, interestingly, some patients are doing some dramatic things with cardiac function and some are not, whether that's to do with cells, whether it's to do with myocardial recovery from the angioplasty. We'll find out at the end of the full-blown study. Where are we at? Well, you can imagine it's an incredibly difficult trial to recruit for because we have to actually try and gain consent in the emergency situation with the patient coming in at the same time that we're gaining consent to do primary angioplasty on them. So, as you can imagine, a lot of these patients just aren't interested in being interested in research. And I was asked to comment on a radio program not so long ago about whether it should be mandatory for patients across Europe to be included in this type of emergency research and that they'd have to actually opt out. A bit similar to the question about organ transplantation, that actually organ transplantation should be an opt-out across Europe rather than an opt-in based on the falling amounts of transplantation that are taking place. And really, to do emergency studies, it is totally unrealistic to think of anything called informed consent in the emergency environment. It just doesn't happen. And so ethics committees and clinicians alike, I think, need to tackle the problem of how you do emergency medicine-based research. Because there's no way a patient will take on board complex procedures like this. That's absolutely out of the question. So the ones that say yes, I have no idea why they're saying yes. It's certainly not because they're fully aware of what's going on in the study. And like the ones that are saying no, I'm sure are pretty much unaware of what the study's all about and the potential benefit the study might be of them. Anyway, 61 patients recruited. This study is actually pan-European-ish in that we've got 2 other hospitals in the UK recruiting these patients. We also have Copenhagen and Lausanne are about to start. And again, we're hoping to finish sometime this year, but very slow to recruit. Finally, the dilated cardiomyopathy group of patients. So based on this paper, which essentially came from the German group, suggesting that in an uncontrolled trial, there is some highly significant improvement in ejection fraction in a group of patients that are presumed not to get better. And of course, the presumption here is that they haven't got some form of viral cardiomyopathy which will get better, and hence why you need your randomized controlled trial. But very tantalizing data to suggest that bone marrow cells might well improve cardiac function. So here's our randomized controlled trial. And again, we wanted to make sure that we had an interventional arm, so that's intra-coronary injection of cells for two reasons. Intra-coronary because, of course, with dilated cardiomyopathies, these patients do not have obstructive coronaries. And also, our ethics committee would not allow us to use the intra-myocardial approach in the dilated cardiomyopathy group for that very reason. So no intra-myocardial arm there. And again, you've got cytokines GCSF asking that tantalizing question, can a simple injection actually benefit these patients? There is, again, some anecdotal data from a group in Bristol in which there is a hematologist who actually treats children with very rare blood disorder that also leads to heart failure. And his anecdotal report to me suggests that GCSF administration to children who get heart failure leads to improvement in their cardiac function. He's never published it. He seems to put it routinely into his practice. But there's enough sort of data out there for allow us to do this basically proof of principle, proof of concept type trial, randomized controlled trial, and there'll be 60 patients in it. Again, this study has gone incredibly well, so it's taken us 8 months to actually finish recruitment for it, and that's simply because we have a very organization in the UK for patients who've got dilated cardiomyopathy, so they're very well informed. They always attend these meetings, which happen in London and also regionally. So all you have to do is attend one of these meetings, put up your trial, and the next thing, all these people come and enroll in it. So it's been great. And it's got a 6-month endpoint, so we should get some results again for this year. So in summary, 6 years of work in the field, looking at 3 different types of cardiovascular disease, and we're close to getting some very important answers, which I hope will make a difference. But how on earth are we going to convey that to all our skeptical colleagues out there? Because ultimately everyone will be fixated on this problem of 3.5%. We are not going to see 40% improvements in cardiac function in human beings. In fact, I challenge any therapy other than heart transplantation to do that. But how on earth are we going to get the message across? Well, the first thing to say is obviously with cardiac MRI, we're much better at detecting 3.5% improvements in cardiac function. So part of the game is won. Previously, when we were relying on echocardiography and nuclear medicine, people would argue you can't even measure 3.5%. And in fact, your ejection fraction will improve by 3.5%, if not 5%, just standing up from the chair that you're sitting in at the moment. And we've never been able to measure that. So for the first time with cardiac MRI, we have been able to measure it. Of course, it's never quite that simple because with cardiac MRI, despite the fact you can cut your stacks at various 5 to 6 millimeters, you're still left with a manual process of trying to trace the edges. And even with the eye of faith, if you look closely at this, you see that these edges don't actually match the edges that are in there. So sometimes people use automated software to try and do edge detection. Those that want, I guess, a real answer, need manual labor. So the reason I sent my data back was because they'd used an automated edge detection software with manual override to do my ejection fraction calculations. And I basically said, right, well, that might cut down your analysis time from 4 hours per scan to 2 hours, but I need the 4-hour manual thing because I don't believe in automated software at this moment in time for these trials. So there are pitfalls even in our fantastic modern technology, such as cardiac MRI, that we have to be very careful of when measuring that. But the real killer answer to the question about ejection fraction and where you go with ejection fraction is this retrospective analysis that was published in JACC about 2 or 3 years ago, in which the authors basically looked at retrospectively the changes in cardiac function that occurred in various pivotal trials that changed the way we practice cardiology. And lo and behold, even in events such as primary angioplasty, the improvements in cardiac function are in the order of magnitude that we've already seen in cell therapy, in the meta-analysis and some of the individual trials. And of course, here some of the studies, so PTCA versus RTPA, that was the original Grimes paper in 1993, and you could argue they didn't have stents in those days, so of course, that's the issue. But that showed a significant mortality benefit from PTCA versus fibrinolysis, 0% difference in cardiac function. So it goes back to my point about we have to be very careful in translating medicine and our use of animal models. We have to really understand the limitations of animal models and accept that if you're going to use a surrogate endpoint like ejection fraction, 40% in a mouse is certainly nowhere near that in a human being. And equally, in the mouse, you don't know if that 40% improvement actually is going to lead to that mouse living longer because, of course, you are in control of their destiny, and those unfortunate creatures get sacrificed so that we can look at histology. And the question therefore arises is what change in ejection fraction needs to occur in a human being to actually make a difference. And maybe ejection fraction is actually the wrong measure. Maybe we need a new tool that cardiac MRI and perhaps nuclear medicine can come up with that's called cardiac performance. Because ultimately we want to put into the equation not just how effective the heart is as a pump, we want to know how efficient it is in its use of energy consumption, because no doubt that will have a part to play in how long you're going to live. And goes back to our other concept about we're all born with a certain number of heartbeats. We don't know how many heartbeats that is, and when you finally reach that number, your heart will stop. So there might be some pre-programming involved in this whole thing as well. But I challenge you, I'd suggest that ejection fraction and anatomical descriptors of cardiac function are perhaps not the best tools that we need for translational research. And I do wonder about all the other therapeutic approaches that have fallen by the wayside because they run into a similar problem without realizing that the tools we're using to try and translate what happens into a mouse into a man are not potentially good enough. So one way of trying to change that is to actually try and do something different. If we're not going to get answers with cardiac MRI that will satisfy us, what can we learn from the preclinical work that's been done that might well convince people? So endpoints, cardiac MRI, as I said, I think gives us a surrogate measure, but we're talking 3 or 4%, not 40%. Targeting delivery, there's certainly in the cell therapy area a lot more need for targeted therapy. The NOGA system I spoke to you about for intramyocardial delivery might well be the best system, but it's practically one of the only systems that stood the test of time, and as I said, costs a lot of money. So either we're going to be injecting these cells and potentially new cells blindly into the coronary circulation and hoping they get to the right place, or we're going to have to develop better ways of targeting and cheaper ways of targeting because, of course, 3,000 euros per patient is a heck of a lot of money. But ultimately what the field is missing is mechanism. So I think one of the biggest problems that translational research faces is that we don't have tools to understand mechanistic explanations of what goes on. So of course you can't reproduce this slide that you see on the right here from Ulrich and all in human beings because you do not have access to the histology for obvious reasons. And that's why I think one of the most important emerging areas in translational research has to be molecular imaging. And I know it's something we've spoken about for a long time, but I'm very fortunate enough to have a collaboration with Yale in the US and a very forward-thinking and bright guy called Al Sanusis, who's a cardiologist, but his expertise is in advanced imaging. And you can see that although as a jobbing clinician I wasn't aware that most of this stuff was happening, there is quite a lot that's going on in the area of molecular imaging that might give us some of the clues to mechanism that in combination with surrogate endpoints and actually targeting cells will convince us or enable us to actually evaluate the effects of cell therapy and other new biologics in years to come. And I'm pleased to say that we've, through this collaboration, been involved in a first-in-man type project in which there's essentially GE has developed a radioisotope ligand to the alpha V beta 3 integrin. So the alpha V beta 3 integrin is interesting because amongst the various things it does, it's activated in angiogenesis. So only active angiogenesis do you find expression of this particular integrin in and around the context of ischemic heart disease and myocardial infarction. And what they've developed is a technetium label where they can actually label it with all sorts of things now, RGD peptide, that binds the alpha V beta 3 integrin and gives us perhaps a way of trying to identify mechanism and what's going on. In the preclinical work. Here you're looking at a dog model, and again you're looking at nuclear imaging. So this is cross-sectional anatomy of the heart, and you can see the arrows pointing to the actual sites of myocardial infarction, and also an increase in the technetium label in and around those sites, suggesting that in the canine model of myocardial infarction, 3 weeks following that, there is an active process of angiogenesis that goes on in and around the actual infarct. And this isn't cell therapy, this is purely normal pathophysiology. And I think some of the other benefits of advanced imaging allow us to do fusion imaging, where you can combine CMR and CT, if necessary, with these nuclear pictures to actually get you a co-localization of your signal. In this case, it's coming from radiolabeled ammonia or fluorine-labeled RGD peptide, to demonstrate that in areas of late gadolinium enhancement, you can probably just about see the arrows along here. So this is a myocardial infarction model, cardiac MRI, long axis, and you can see an uptake of tracer and then co-localization of the fluorine RGD peptide down here, suggesting angiogenesis actually at the apex of the ventricle. So great stuff, and as you can see at the top, this is actually done in a patient. So for the first time, we've demonstrated, using this peptide, the suggestion that there's a process of angiogenesis that's going on. And for the very first time, so nobody else has really seen this data as yet, we've applied this to our trial. So in our REGENERATE-IHD trial, patients with heart failure receiving cell therapy, we've been able to label some of our patients with this angiogenesis peptide marker. And what you can see, and as I say, it's early days, we don't know what it means, is that this sort of U-shaped structure is the heart, the whole thing is the thorax, with the signal that's picked up using the scintillation counter. And what you can see over here, maybe with the eye of faith or not, is that the red just around the borders seems to have got a lot better. So again, the first indicators in the model of cell therapy, and it's a human model of cell therapy, that a mechanistic process, and here we're talking about angiogenesis, might be going on. As I said, we've only just unblinded the study, so we need to actually sit down and look at these scans. And as you can imagine, because it's a first-in-man thing, there's going to be quite a lot of working out exactly what's going on here. But I think it's this approach and molecular imaging that's actually going to give us additional tools that we're going to be able to use in translation. So what does the future hold? Well, there's certainly other cell types that you'll be aware of, and I'll touch on. Molecular imaging, I think, is going to play a very important part. But I think, finally, the thing that we need to consider is whether we move forward into the brave world of phase 3 clinical trials or not. Because ultimately, it's the phase 3 clinical trials in the absence of surrogate markers that we can believe or that we don't debate that are going to tell us whether the new therapy should be accepted. On the cardiac stem cells, as you know, the textbooks have had to be rewritten because the myocardium does possess niches of cells that are able to self-replicate and regenerate the heart. So this concept has been taken forward in some clinical trials. We knew as far back as 2003 the existence of these cells, but it's taken about 8 years for the first clinical trial, which was published most recently in the Lancet, to come out. So this was the SCIPIO trial. And the authors here, again, it was mainly based on safety, but have looked at efficacy, suggest there's an improvement in cardiac function with patients treated with cardiac-derived stem cells, that for the first time they make the claim, and again it's a surrogate claim, that they've used cells that actually increase myocardial mass. So whether myocardial mass is a direct result of cells growing is the actual mechanism or not, I don't know, and of course they plan to do a large randomised controlled trial. I'd say, in contrast to bone marrow cells, obviously producing these cells is quite a challenge. You have to take biopsies from these patients' hearts, you have to culture these cells, you're thinking about cost, you're talking about facility, and you're talking about which centres can do it. The challenge, I think, for the cardiac stem cells is they're going to have to come up with an answer bigger than 4% in ejection fraction, and somehow I don't think that they're going to do that in a large-scale trial. The other exciting area of cell types is the mesenchymal stem cell. They're seemingly abundant, they're seemingly relatively easy to isolate in culture, and they seemingly have the potential to do all sorts of things that you might find beneficial in repairing or restoring heart function, ranging from pacemaker cells all the way down to myogenesis. And again, the field has lagged behind bone marrow cells because obviously it's taken quite some time to work out how to produce these cells, but this early study looking at mesenchymal stem cells injected intramyocardially again suggests that there's an improvement as far as MACE-free survival and cardiac-free death. And again, I think the challenge of the engineered cells is, are they any better than the bone marrow cell? The SCIPIO trial is an engineered mesenchymal stem cell, so engineering or engineered cells is the actual theme of what's going on here. And again, in this study, they basically demonstrated the safety and also efficacy endpoints, although they were using ejection fraction and echocardiography, which in such a small number of patients I find quite a remarkable feat, given the degree of variation we have in our echo techniques. Nonetheless, they seem to demonstrate safety and efficacy, and as you can see, they're aiming for a 200-patient study or so. The other reality check that we have to really put into play is the expectation that the medical field has here. So every time you make these presentations, you're challenged with the fact as to why nothing's happening in the field of cell therapy. And the answer is because if you were developing a drug, you wouldn't even have heard about it, because most of the drugs that we use from discovery to phase 1 and phase 2 or 3 are approximately 10 years in the pipeline. And that's 10 years hidden away in industry, in a dark box somewhere with a code name or code number that we as clinicians are never exposed to, or scientists. And what's different, obviously, about cell therapy is we've been exposed to it right from the very beginning, from the discovery phase. So if you actually readjust the timelines to where we are with cell therapy, what should we be doing? Well, I think Manuel, you probably agree, we've probably been in the game for about 10 years or so now. And after 10 years of discovery through preclinical phase 1 and phase 2, you'd expect to be doing phase 1 or phase 2 trials. And indeed, I think the future is the proliferation of stem cell trials, progenitor cell trials throughout the world. And as you can see, there's a healthy number going on, not a massive number, but a healthy number. So I think the field is live and cooking. But what is it we need now? I think what we'll see from the data that I've shown you is that there's probably enough information to suggest that we need to do a large-scale clinical endpoint trial to actually work out what's going on. And the most convincing data we've got to date comes from the Frankfurt group, and this is the REPAIR AMI trial. They demonstrated a highly significant trend to reduction in cardiac endpoints, including death, MI, and rehospitalization in their 200-patient study, which was never powered to look at outcome. So it's with that in mind that we've had, I think the field has had a tremendous breakthrough in that the field as such has been funded through the EU FP7 program to produce the first ever phase 3 clinical trial of stem cell therapy in acute myocardial infarction. And your centre, of course, is one of the partners in that. The trial itself is, again, very pragmatic. We're not here to test mechanism, we're here to test outcome. So the endpoint of this trial is a 25% reduction in death of all-cause mortality at 2 years. Our power calculations suggest we need about 3,000 patients to do this. It's a pan-European study. The protocol is being finalized, and it's essentially based around the Frankfurt protocol, which I showed you a slide on a minute ago, in which we saw a trend to an improvement in cardiac outcome in those patients. But what we're going to do is compare the whole bone marrow aspiration and injection procedure to standard care. So that's 1,500 patients will get the bone marrow aspiration and reinjection of cells, and 1,500 patients who are randomized based on their ejection fraction being less than 45% will get standard care. They'll all be followed up for 2 years, although it's an event-driven study, and the plan is that the study will end when 400 events have been recorded, which is essentially a 25% mortality, the event being myocardial infarction. There are 21 partners across the whole of Europe, with 11 countries involved, and there will be the opportunity for many more satellite sites to be involved in recruitment, this rather ambitious number of patients. And there's a website that will keep everyone updated as to where we go. So I think with that, the field is live and kicking. The field actually is probably ahead of the game if you're comparing it to pharmaceutical developments, because we're now embarking on the phase 3 trials. And I've heard recently there are 2 other phase 3 trials of other types of cells that are also going to be out there. I don't think anyone's planning a 3,000 patient study. We're talking several hundreds of patients. So the 3,000 patient study of bone marrow cells after acute myocardial infarction is clearly going to be very important, not simply because of the fact that it will give us an answer. It's more the case that I think we've proven that we have been able to translate as a group, and that's a group that involves basic scientists and clinicians and obviously patients, that we outside of industry and pharma can translate in a period of time perhaps even quicker than pharma does. Thank you very much.